Hi, my name is Andrea Yardo, and I will be discussing the topic of achondroplasia. So let's get started. So we'll be starting with the genetic principles. And so achondroplasia, which is also known as ACH, is a hereditary dwarfism. And that is caused by the disturbed proliferation and differentiation of growth plate chondrocytes, followed by the impaired endochondral bone growth. And chondrocytes, they are the healthy cells found in cartilage. And so ACH may also be caused by mutations in the FGFR3 gene, and that stands for fibroblast growth factor receptor 3. And that gene is involved in the development and maintenance of bone and brain tissue. And most cases of ACH are not inherited, but when achondroplasia is inherited, then it is in an autosomal dominant manner. So next we will be looking at the phenotypic features. And so individuals with ACH, they have a short stature with rhizomelic shortening. And what that is the shortening of the limbs. For example, shortening of the arms or shortening of the upper thighs. And other phenotypic features are a relatively large cranium, a protruding forehead, a flattened nasal bridge, protrusion of the mandible, and hypoplasia of the midface. What hypoplasia is, it is when the cheekbones, upper jaw, and eye sockets, they have not grown as much as the face. And another phenotypic feature is trident configuration of the hand, and I will show you what that looks like. So if you look here, you're able to see these two fingers together, and then the thumb. And so it has the shape of a trident. And so next we'll be looking into history and physical findings. And I found a case study of a 4-year-old male. And since the age of 3, he had slow development growth. He began teething at around 7 to 8 months of age, and he began walking at age 1. And after 1 year of age, his growth and development, they were slow, and his height was lower than other children in the age group. And so what was interesting to me was that his weight and intelligence were normal. So he was not affected by any way with the genetic disorder. He was not affected by it in that manner. And so the child did show phenotypic features such as a large head with a prominent forehead, disproportionate shortening of the upper arms and legs, and short hands with trident fingers. And so um, in the case study, the researchers ran laboratory tests and growth hormone provocation tests, and the laboratory results indicated that the test for antibodies against TSCH receptor, thyroid peroxidase, and thyroglobin, they were all negative, and um, of his levels of sex hormones, cortisol, and adrenocorticotropic hormone, which is ACTH, they were all normal. And they also took a growth hormone provocation test, and that indicated that his growth hormone responses were normal. But when he was tested with arginine, he had a blunt response, and that was shown in a graph in the document that I read. And also, his growth hormone level during exercise was also low. And so, in the document that I saw, the case study, these were the pictures shown. And so, the one labeled A, you are able to see the trident configuration in the hands. And something interesting to me that I learned from the case study was that you're able to see the age of of the wrist bones because when looking at the radiograph, the researchers and scientists, they were able to see that the the um, the age of the wrist bones was lower than the age of the child. That was very interesting to me. And this is another radiograph taken of the patient's limbs, which revealed disproportionate shortening. And so, um, the patient's disorder was caused by a mutation. Um, the gene mutation analysis revealed that it was a mutation at nucleotide 1138 within exon 10 of the FDFR3 gene. And so the missense mutation caused the substitution of glycine and arginine at amino acid position 380. And the patient did receive treatment, and that was the oral therapy with recombinant human growth hormone and levothyroxine. And after about 6 months, his height improved, his arm span to height ratio and lower limb length to height ratio also increased. His head circumference decreased, and there was no abnormality on thyroid function and sex hormone tests. And so, as you're able to see in this picture, the one labeled A and B, they are the normal control. And so A is homozygote DG and B is homozygote CC. And so the ones labeled C and D, they are patients with achondroplasia. And as you're able to see in C, it is heterozygous AG and D is heterozygous DC. And so you're able to see the mutated bases with the arrows. Okay, and we'll be going into disease etiology and pathogenesis. And more than 90% of patients with ACH, they have a gene mutation at G1138A in the transmembrane domain of the FGFR3 gene. And it is estimated to affect more than 250,000 individuals, and the incidence rate is 1 in every 10,000 to 30,000. And if ACH is inherited, it follows an autosomal dominant pattern of inheritance. And about 80% of individuals, their parents have an average normal stature, but they are born with the condition because of a new gene mutation that is also known as de novo. So, what? Okay, so here the researchers, they took a blood sample from a 2-year-old male, and you can see the FGFR3 gene mutation, and that is indicated by the red arrow here. So, in order to be able to make a good diagnosis, medical professionals have to take the medical history, look at the symptoms, make a physical exam on the patient, and look at the laboratory tests results. And the laboratory tests may include blood samples or the growth hormone provocation tests that I mentioned earlier, and the physical symptoms or the physical diagnosis that the medical professionals may make are the large cranium, protruding forehead, flattened nasal bridge, protrusion of the mandible, hypoplasia in the midface, pattern configuration of the hands, and the rhizomelic short stature. And so next we will be going into treatment for achondroplasia, and that includes oral therapy with the recombinant human growth hormone and levothyroxine. And what would need to be monitored would be height, weight, and head circumference. And also weight may need to be monitored at a very early age to avoid obesity. And for further evaluation, an MRI or CT scan may be taken because it may be needed for severe muscle weakness or spinal cord compression. And to help the individuals with breathing, that may include surgical removal of adenoids and tonsils, or a continuous positive airway pressure by nasal mask, or a surgical opening in the airway. And also, another treatment may be limb lengthening procedures for height. And so next, we will be going into inheritance risk. And like I mentioned before, about 80% of individuals with ACH have parents with average stature, and they are born with a condition as a result of a new gene mutation. And a person with, or well, if a person has a partner with ACH, they have a 50% chance of having a child with ACH. But if both parents, if both of them have ACH, they have about 50% chance of, excuse me, they have 25% chance of the child being born with normal stature. And if, again, both parents have ACH, they have 50% chance of having their child be born with ACH. But what I found very extremely interesting is that if both parents have a child, the child may inherit the gene mutation from both parents, and that is 25%. And but the inheritance of the gene mutation may lead to a condition called homozygous achondroplasia, which unfortunately leads to death. And so you're able to see achondroplasia at a very, oh my God, excuse me, at a very early age in the womb. And as you can see right here, you can see the protruding forehead and the short femur. And so this is my photogenic tree. And this is the Suri mangabe, this is the Galletta, right here is a green monkey, and this is a silvery gibbon, and then the northern white-cheeked gibbon is right here, and then the Homo sapien, the little baby, and then the chimpanzee, and the Panamanian white-faced capuchin. And so next we have my citations. And so I hope you enjoyed my video, and thank you for watching. Bye.